Yes, visible and
It's
Yes,
visible.
visible and
Okay.
audible.
So
Visible
that
and audible.
okay. My sincere thanks to seniors and colleagues of Trichy IAP for their presence and support here. So rational use of antibiotics in pediatric practice is a topic nalla thochu alasi discuss panna topic adu. But Anna, every time we see a prescription, we realize how little we actually think of whatever we learn, but we fail to implement it in our OPD practice. My sincere thanks to Dr. Kritika Murugesan. Ismail sir சொன்ன உடனே அடுத்த நிமிஷமே அவங்களோட ஸ்லைட்ஸ் எனக்கு இமெயில்ல அனுப்பிட்டாங்க. It made it very, very easy for me to prepare a short presentation myself. Thank you so much, Dr. Kritika. Before we talk about antibiotics, a session on antibiotics is incomplete if we do not pay our respects to this man. This is Sir Alexander Fleming. He went on a short holiday with his family. கிளம்பி போகும்போது வீட்டில் ஒரு கல்ச்சர் பிளேட்ல ஸ்டெஃபலோகாக்கஸ் வளர்த்து விட்டுட்டு போனாரு. When he came back, he saw that the staphylococcal colonies had grown, but there was something else, a mold that was growing on the same plate, which was inhibiting the growth of the staphylococcus. So wherever the mold was present, staphylococcal growth was being inhibited. Wherever the mold was absent in the rest of the petri dish, staphylococcal was growing in abundance. So he knew that there was some factor in the mold which was inhibiting the growth of this bacteria. He called this mold juice. And this was the beginning of having the first antibiotic, penicillin. So in those days, 1928 அவர் penicillin கண்டுபிடிச்சாரு. அப்பவே அவர் சொன்ன வார்த்தைகள் இது. The microbes are educated to resist penicillin and a host of penicillin fast organisms is bred out. In such cases, the thoughtless person யாரு? நம்ம. In such cases, the thoughtless person is playing with penicillin and is morally responsible for the death of the man who finally succumbs to infection with a penicillin-resistant organism. I hope this evil can be averted. He cautioned not to use penicillin unless there was a properly diagnosed condition for it to be used. And even if you use it, don't use too little and don't use it for a very short period, since these are the circumstances under which bacterial resistance to antibiotics develops. Penicillin kandupidichavare, he warned us against the rampant use of an antibiotic in inappropriate dose and for inappropriate duration. So remember before God, so if we are able to manage so many diseases, it's because of two reasons. One is because of vaccines and the other is because of antibiotics and intensive care management. So this man comes before God. So let us listen to what he says and start practicing it. So what is the rationale behind an antibiotic prescription? Prescription writing is an art. இப்போ ஜோசியக்காரங்கள்லாம் எப்படி ஒருத்தங்களோட ஜாதகத்தை பார்த்து அவங்க எப்படி இருப்பாங்க அப்படி இருப்பாங்க அவங்க கடந்த காலம் அப்படி இருக்கும்லாம் சொல்றாங்களோ, நம்ம ஓபில உட்காந்துக்கிட்டு ஒரு பேஷண்ட் ஒரு பிரிஸ்கிரிப்ஷனோட வெளியில ஒரு டாக்டரை பார்த்துட்டு வராங்கன்னா அந்த டாக்டர் என்ன மாதிரி டாக்டருங்கிறத அந்த ஒரு சீட்டு பிரிஸ்கிரிப்ஷனை வச்சு நம்ம கண்டுபிடிச்சிடலாம். டேட் இருக்கா, பேஷண்டோட பேரு பார்த்தா புரியுதா, பீடியாட்ரிக் பிரிஸ்கிரிப்ஷன் வெயிட் எழுதியிருக்காங்களா, மெடிசின்ஸ் நமக்கும் புரியுதா இல்ல அவங்களோட ஃபார்மசிஸ்டுக்கு மட்டும்தான் புரியுதா, dose and duration எழுதியிருக்காங்களா, and is there any rampant use of unnecessary steroid or antibiotic prescription. இதெல்லாம் பார்த்தாலே இன்னொரு பீடியாட்ரிஷனை பார்க்காமே நம்ம அவங்க என்ன மாதிரி டாக்டர், அந்த ஊர்ல ஒரு டாக்டர் இருக்காங்க, நம்ம பேஷண்ட் அந்த ஊருக்கு போறாங்கன்னா அவங்களுக்கு ரெஃபர் பண்ணி அனுப்பலாமா வேண்டாமாங்கிறத ஒரு சீட்டை வச்சு நம்ம கண்டுபிடிச்சிடலாம். So your prescription reflects who you are as a practitioner. It is not just between you and the patient, it is going out into the community. So think before writing down a prescription. So reasoning for the prescription irkano. So what is the dose, what is the route going to be, and for how long are you going to write the medicines? Take academically updated decisions, train yourself, train the pharmacist. If this medicine is not available, avanga odane badalukku vera edho onnu kudutara kodadu. They should always remember that they are there to dispense medicines and not to treat the patients. Train the parents. Most often they come back. அடுத்த இல்னஸுக்கு உங்களோட போன வாட்டி வேற ஏதோ ஒரு இல்னஸ்க்கு நீங்க எழுத ஆன்டிபயோட்டிக் சீட்டை கொண்டு வந்து காட்டுவாங்க. டாக்டர் நாங்க வந்து இந்த ஆன்டிபயோட்டிக் 7 நாள் கொடுத்து முடிச்சிட்டோம், உடம்பு இன்னும் சரியாகல. ஸோ வாட் ஆர் வி சப்போஸ் டு டூ நோ? நம்ம இப்ப இன்னும் வேற ஆன்டிபயோட்டிக் போடணுமா? ஆர் டு வி ஹேவ் த ரெஸ்ட்ரெயின்ட் டு கன்வின்ஸ் த பேரண்ட்ஸ் தட் தி ஆன்டிபயோட்டிக் இஸ் ஆக்சுவலி நாட் நெசசரி ரைட் நவ், அண்ட் கிவ் கிளியர் இன்ஸ்ட்ரக்ஷன்ஸ் டு பேரண்ட்ஸ் when to use and when not to repeat a prescription. Organism search, if possible evidence based practice பண்றது is best. Note down the diagnosis. Always in every prescription, there must be an empirical diagnosis. Have a strict antibiotic policy in your hospital or nursing home. Know the local sensitivity pattern. for your community, for the hospital where you practice, as well as the patient. If the patient is having recurrent infections, go back to their investigations, look at the organism that is growing and its sensitivity pattern before you write down an antibiotic this time. And ethical and economic considerations are always important. So இத்தனையும் மீறி நம்ம ஏன் ஒரு பிரிஸ்கிரிப்ஷன்ல ஆன்டிபயோட்டிக் எழுதுறோம்? Why do I sometimes write an antibiotic when the picture is clearly viral? My prescription feels incomplete without an antibiotic. ஒரு ஆன்டிபயோட்டிக் கூட எழுதாம ஒரு சீட் நம்ம கொடுத்துட்டா அப்புறம் எப்படி பேஷண்ட்டுக்கு சாட்டிஸ்ஃபை ஆகும்? அண்ட் வாட் இஃப் த இன்ஃபெக்ஷன் வர்சன்ஸ்? அவங்க பாட்டுக்கு போயிட்டாங்கன்னா அப்புறம் வைரல் இன்ஃபெக்ஷன் செகண்டரி பேக்டீரியல் ஆயிடுச்சுன்னா அப்புறம் ரொம்ப சிக்காயிருவாங்களே. ஒரு சேஃப்டிக்கு நம்ம ஆன்டிபயோட்டிக் போட்டுக்கலாம். பாராசிட்டமால் கொடுத்தாலும் ஃபீவர் குறையல, அப்ப கண்டிப்பா we have to give an antibiotic. The mother has already used ceftodioxime from a prescription that you gave last time and now she has come. So she's not going to be happy if you don't give another antibiotic right now and reassure her. So let me write an antibiotic right now. Yesterday I gave amoxicillin and the child has come back today. If I don't add something powerful today, mother is not going to be convinced. Recently there was a child who was admitted to the short febrile illness, 5 days duration. First day cefotaxime, second day ceftriaxone, third day betnosol. This was a pediatric prescription. So what are the common bacterial infections that we are going to go into? URI, upper respiratory infection, lower respiratory infections, acute bacterial rhinosinusitis, acute dysentery, urinary tract infection, skin and soft tissue infections. இதெல்லாம் பிரீஃபா பார்ப்போம். All my references are from Nelson. வெளியில எங்கேயுமே நான் போகல. So upper respiratory tract infection na நம்ம acute pharyngotonsillitis, acute bacterial rhinosinusitis and acute otitis media பார்க்க போறோம். So MEC-ISAC criteria was initially used in adults. அதை modify பண்ணி modified center criteria னு pediatric practice-காக கொண்டு வந்திருக்காங்க. A score of 4 or more is indicative of an acute pharyngotonsillitis. So fever இருந்ததுன்னா ஒரு பாயிண்ட், டான்சில் எக்ஸுடேட் இருந்ததுன்னா ஒரு பாயிண்ட், காஃப் இல்லைன்னா ஒரு பாயிண்ட், anterior cervical lymphadenitis இருந்ததுன்னா ஒரு பாயிண்ட். If the age is between 3 and 14 years, you give 1 point. If the age is more than 44 years, you take away a point. இது ஒரு சின்ன சீட்டு மாதிரி நம்ம ஓபில வச்சுக்கிட்டா கூட it will be useful for us. So a 6-year-old boy is brought with complaints of high-grade fever, odynophagia and sore throat. You do a quick analysis and clinical examination, you know it is acute pharyngotonsillitis. You apply the Centaur scoring, your score is more than 4. So you, if possible, you do a throat swab and culture and you know that it is group A strep pharyngitis. Rapid streptococcal antigen test தான் நம்ம ரொம்ப பண்றது கிடையாது. Treatment is going to be amoxicillin oral 50 mg per kg per day for 10 days duration. Insist on their completing the course even after the child shows clinical improvement. What will happen if I don't treat an acute bacterial upper respiratory infection? முக்கால்வாசி குழந்தைகள்ல தானாவே சரியாயிடும். பட் நம்ம எதுக்காக ஆன்டிபயோட்டிக் எழுதுறோம்? First reason is it hastens recovery. It reduces suppurative complications. மூணாவது, if the antibiotic is initiated within 9 days of onset of illness, you will be able to prevent acute rheumatic fever. Acute bacterial rhinosinusitis is a clinical diagnosis. இதுக்கு investigation எதுவுமே தேவையில்லை. So when do you suspect? If the child has high-grade fever more than 1 or 2 with purulent nasal discharge of more than 3 days duration, if the child has rhinorrhea and persistent cough of more than 10 days duration without an improvement, if there is delayed worsening or double sickening, கொஞ்சம் improvement ஆகிற மாதிரி ஆயிட்டு அதுக்கப்புறமா child worsens, so it may be a viral infection with a superimposed secondary bacterial infection. Sinusitis, 50 to 60% of the kids will recover without any antibiotic. Antibiotic is given only to resolve symptoms and to prevent suppurative complications. Never ever prescribe azithromycin for a child with sinusitis because there is known to be a high prevalence of antibiotic resistance. Trimethoprim sulfamethoxazole also is not advisable. So a 3-year-old child is brought with history of nasal discharge with cough of 12 days duration, not improving with symptomatic treatment. So you have given your antitussives and antihistamines, child is not getting better. Your clinical diagnosis is acute bacterial rhinosinusitis. You know the organisms are going to be pneumococcus, H. influenza and moraxella. Investigation எதுவுமே தேவையில்லை. Straight away go off for amoxicillin 45 mg. அதாவது amoxicillin we have 2 spectrum. ஒன்று 45 mg per kg per day. Some certain other infections you give 80 to 90 mg per kg per day. So for ABRS we give amox 45 mg per kg per day for 10 days. Certain small group of children க்கு மட்டுமே you give high dose amoxicillin clavulinate. யாரு age less than 2 years, the child is going to daycare, and if there is non-response to amoxicillin within 72 hours of initiating, then you give amoxicillin clavulinate 80 to 90 mg per kg per day for a period of 10 days. Acute otitis media. Acute otitis media இருந்ததுன்னு கன்ஃபார்ம் ஆச்சுனாலே we are going to give antibiotics. There is no role for waiting and watching unless you are uncertain about the diagnosis. So 3 strong arguments in favor of prescribing antibiotics are: one, acute otitis media is invariably because of pathogenic bacteria. Initiating an antibiotic gives prompt resolution of the symptoms, and you're going to prevent suppurative complications. If the age is less than 6 months, you do not have to see pus in the ear. You do not have to see a red tympanic membrane glaring at you. You know that the baby is feeding in the supine position, maybe a bottle fed baby. கிளினிக்கலா நமக்கு அந்த ட்ராகஸ் மேல ஒரு லேசா ஒரு பட்டன் பிரஸ் பண்ற மாதிரி பிரஸ் பண்ணி குழந்தை வீல்னு கத்திச்சுன்னா, and you look பொட்டோஸ்கோப் வச்சு நம்ம பார்க்க போறோம். பட் 3 மாச குழந்தைக்கு காது ஓட்ட வழியா நமக்கு கொஞ்சோண்டு வேக்ஸ் தெரிஞ்சாலே பெருசு. நிறைய தடவை நமக்கு டிம்பானிக் மெம்பரேன் தெரியாது. இஃப் யூ நோ சைல்ட கம்போஸ் பண்ணி மதர் மடியில வச்சு ஃபீட் பண்ண வச்சுட்டு ஃபீட் பண்ணும்போது இந்த பிரசன்ஸ் ஆஃப் அ ஃபீமேல் ஸ்டாஃப், இஃப் யூ ஆர் அ மேல் பீடியாட்ரிஷியன், குழந்தையோட ஒரு ட்ராகஸை லேசா பிரஸ் பண்ணுங்க. If the child is not crying, then press the other tragus of that ear. If the child just lets out a high squeak and starts wailing inconsolably, you know the child is having acute otitis media. You need a big investigation for this. So in a child less than 6 months of age, you treat even if there is presumed acute otitis media. In a child between 6 to 24 months of age with high grade fever, child is toxic and if there is severe ear pain, then you treat. The child is saying that there is ear pain, but the child is looking absolutely comfortable. You can give symptomatic treatment, ask them to come back after 2 or 3 days and reassess. A child with age more than 2 years, only if it is a case of severe acute otitis media or if it is confirmed clinical, நமக்கு பார்த்தா TM தெரியுது, you're able to see an effusion or if there is pus coming out or if the TM is red, then you're going to start antibiotics. A child less than 6 months of age, even presumed acute otitis media, you're going to treat with high dose amoxicillin, 80 to 90 mg per kg per day for a period of 10 full days. Second line drugs are amoxiclav, cefuroxime. Child has vomiting, child is sick, oral intake கொடுக்க முடியலன்னா ரொம்ப ரேரா நம்ம ceftriaxone 3 days கொடுத்துக்கலாம் அட்மிட் பண்ணி. A child more than 6 months of age, you're going to treat if it is severe or if it is a case of confirmed acute otitis media. What about bacterial pneumonia? The factors to keep in mind for bacterial pneumonia are age of the child, the clinical appearance of the child, OP-ல ட்ரீட் பண்ணலாமா, inpatient ஆக்கணுமா, immunization status of the child that is going to help in identifying what could be the possible organism. A 30% of children with viral infections may have coexisting bacterial infection. So நம்ம ஃபர்ஸ்ட் டே வைரல் அசோசியேட்டட் வீஸ் இல்லைன்னா வைரல் LRI வித் வீஸ்ன்னு சொல்றோம். சிம்டமேட்டிக்கா நம்ம மெடிசன்ஸ் எல்லாம் கொடுத்து சம்டைம்ஸ் நெபுலைசர் கொடுத்து அனுப்பிடுறோம். They come back on day 3 or day 4 and the child is looking really toxic. It's okay to change our diagnosis at any point of time when we see the child. We do not have to stick to the diagnosis that we have that நம்ம day 1ல prescription ல எழுதின அதே diagnosis தான் day 3 இருக்கணும்ங்கறது அவசியம் கிடையாது. So always be flexible in your approach. Keep in mind that the child could need antibiotics at any point of time, even in the course of a viral illness. So what is the duration of antibiotics in pneumonia? 10 days. Azithromycin கொடுத்தா மட்டும் தான் 5 days. அது ideally not less than 10 days. Or you can give it until the child has been afebrile for a period of 72 hours. In certain centers, you can use procalcitonin to guide you to look for response. A child in the OPD, child is mildly ill, you know it is LRA, but child is not warranting admission immediately. You can give high dose amoxicillin for 10 days. School going children, adolescents, atypical pneumonia we can suspect, so azithromycin கொடுக்கலாம். So if you have admitted the child and you have a confirmed microbiological diagnosis, then what is the antibiotic tailored for each organism? If it is strep pneumonia, you're going to give ceftriaxone. Group A streptococcus, also ceftriaxone. Methicillin sensitive staphylococcus, you're going to give cefazolin. MRSA, vancomycin or clindamycin or linezolid. If it is MRSA which is resistant to clinda, you give the other 2 drugs, vancomycin or linezolid. Mycoplasma pneumonia, you can start off with IV azithromycin for day 1 or day 2, then change over to oral once the child starts improving. H influenza, you can give ampicillin if it is a beta-lactamase negative organism, else you can go in for ceftriaxone. Nelson talks a lot about minimum inhibitory concentration. So we should all know how to interpret MIC. Minimum inhibitory concentration is the least amount of drug that is necessary to inhibit bacterial growth under control conditions. So if the MIC is less, so in itrondu marundalaye kekuma is what MIC is. If the MIC is more, it means you need more amount of the drug to inhibit the organism from growing, which means probably developing resistance and the medicine is probably not going to act immediately. What about skin and soft tissue infections? We look at impetigo, bullous impetigo and cellulitis. Impetigo, So topical mupirocin 2% or retapamulin. Retapamulin is a pleuromutilin drug. It acts on 50S ribosomal subunit. So if it is a localized impetigo, you use topical mupirocin ointment twice daily for a period of 10 days. If there is widespread staphylococcal involvement, streptococcal impetigo, if the lesions are near the mouth and you cannot apply mupirocin, or if there is an abscess, you give cephalexin for 10 days. If you're suspecting an MRSA organism, then you give clindamycin or doxycycline. Cellulitis or necrotizing infection. So if it is severe, you have to think of one thing is for many physicians, adult and pediatric, when we use antibiotics in a case of a suppurative infection, we always wait for the antibiotic to act. It is not wrong as long as the child is not worsening. But if the pus collection is going to increase, if the child is going to become more toxic, more septic, then it is imperative that we get a surgical opinion that sometimes aggressive surgical debridement can be life-saving. So emergency surgical debridement should always be kept in mind. It's okay to have a surgical intervention, drain the pus and then allow the antibiotic to act rather than wait indefinitely, change the antibiotic. No, sometimes it's okay to not wait. So if it is severe necrotizing infection, you go in for emergency surgical debridement if advised so by the surgeon. Start off with vancomycin and piperacillin tazobactam because vancomycin is for gram-positive bacteria. Piperacillin tazobactam is going to cover the gram-negative ones. You start with this, take off your cultures immediately, and then you proceed based on your culture and sensitivity report. You can always change. If it's a moderate cellulitis, then you go in for ceftriaxone, penicillin, or clindamycin. Mild infection irundadana, oral cephalexin, dicloxacillin, or oral clindamycin is enough. So one thing is get surgeon's opinion at any point of time if you think it is okay to get, and if a surgeon advises debridement, just go ahead. The child is anyway going to get better because of the debridement. And follow up on the culture and sensitivity report. நிறைய தடவை நம்ம ஃபர்ஸ்ட் குழந்தைய பார்த்த உடனே ஆன்டிபயோட்டிக் ஆரம்பிச்சிடுறோம். Many places we do not take a blood culture before starting an antibiotic. Starting from NICU, CRP எடுத்துருவோம், CBC பண்ணிடுவோம். அதெல்லாம் பார்த்து CRP பாசிட்டிவ் நம்ம ஆன்டிபயோட்டிக் ஆரம்பிச்சிருவோம். CRP நெகட்டிவா இருந்தாலும் நம்ம ஆன்டிபயோட்டிக் ஆரம்பிச்சிருவோம். But the culture we don't see. We do look at clinical improvement, but culture is very, very important. So our staff also should be trained. Na culture edun sollana kuda na antibiotic sonna enak phone panni kelu sir na blood culture eduthrava appdinu oru vaartha ketta apparama ni antibiotic first dose poduma appdinu we should always train our staff so that there is nobody misses in the system. Next we go on to GI, acute infectious diarrhea. So this is Nelson gives it organism wise. So most of our diarrhea, most of it is watery, loose stool, no blood in the stool. You know it is going to be a viral diarrhea. There is no need to succumb to the same stress as the mother and start an antibiotic. We can wait. We have to reassure them. We should tell them it's going to last for 7 to 10 days and give them electrol and ask them to monitor for signs of dehydration. And if they're so anxious, ask them to come and review once in 2 days. But starting an antibiotic is not going to help the cause. So if it is the Shigella, then we go in for ciprofloxacin, ceftriaxone, or azithromycin, or a second line drug is cefixime. Enterotoxigenic E. coli is azithromycin or ciprofloxacin. Non-typhoidal salmonella namakku stool culture report vandaduna, you use it only for age less than 3 years, HIV positive 3 months, age less than 3 months, HIV positive patient, any other immunocompromised disease status. In the mari irundha mattumda namba non-typhoidal salmonella we are going to give the same antibiotics as seen in Shigella, but for a normal immunocompetent person, do not treat. It's usually self-limiting. Yersinia, it's usually a self-limiting infection. Ceftriaxone only if the child is becoming bacteremia and if it's an invasive infection, then only you start ceftriaxone. Clostridium difficile, you discontinue the antibiotic which is causing the problem. Then you start the child on vancomycin or metronidazole for a period of 10 days. So this is a classical case of what we see in summer. A 10 months old baby girl is brought with watery loose stool for the last 3 days. There's initially vomiting, now no vomiting. Mother has not given breast milk to the child because pal kuttale baby loose stool pohudunu. Child is irritable and child has passed urine only 4 hours before. This is clearly a dehydrated child. You know that there is no blood in stool, that there is some dehydration, and you know that the cause is viral. There is absolutely no role to give antibiotic to the child. Next we go on to urinary tract infection. Cystitis, simple UTI, complicated UTI. So acute cystitis, send off a urine culture, start a preservative treatment with one of the 3 drugs, trimethoprim sulfamethoxazole, nitrofurantoin, or amoxicillin. This is all okay for a simple cystitis. Ask them to come back after 3 days, look at the culture report, and then change the antibiotic. Whatever is going to be the final antibiotic that you're deciding on, total duration of treatment for cystitis alone is 5 days. Acute febrile UTI, you have to decide between oral and IV antibiotic. Child is stable, having all symptoms of acute febrile UTI, but child does not admission, there's no vomiting, child is hydrated, able to take orally, then you go in for oral antibiotic. If these conditions are not satisfactory or the age is too young, you go in for admission and IV antibiotics. Look at the previous urine culture reports. There are children who have recurrent UTI. Previous organisms எல்லாமே பார்த்தா எல்லாமே ரெசிஸ்டன்ட் ஆர்கானிசம்ஸா இருக்கும். ஸோ இந்த வாட்டி நமக்கு ரெசிஸ்டன்ட் ஆர்கானிசம் இருக்க போகுன்னு தெரிஞ்சதுன்னா we can hit hard and hit fast. We can start the antibiotic based on the previous culture report, and then of course we are going to send another culture this time. So oral antibiotic, we start with cefixime or cephalexin. Avoid nitrofurantoin. Acute cystitis we give nitrofurantoin, but acute febrile UTI where you thinking of pyelonephritis, nitrofurantoin does not reach significant concentration in the renal tissue, so you avoid the drug. Admit panna, you give ceftriaxone or cefotaxime. All this is for a period of 7 to 14 days. As soon as you give the first dose of antibiotic in a child with culture positive UTI, the urine is going to become completely clear within 24 hours. So ஒரு 3 days கழிச்சு இம்ப்ரூவ்மெண்ட் பாக்குறேன்னு சொல்லி இன்னொரு யூரின் கல்ச்சர் எடுக்கிறது சுத்த வேஸ்ட், because the urine culture is going to be sterile after a single dose of the appropriate antibiotic. So there's no point in repeating, as long as you have taken a first culture before starting the first dose of antibiotic. There is no role of antibiotic prophylaxis in a child with first episode of pyelonephritis when the child is having an anatomically normal urinary tract. Suppose you have a 1-year-old child who's having a first episode of culture positive UTI. You've done your urine culture, ultrasound, DMSA, MCU, எல்லாமே பண்ணிட்டோம். Urinary tract is normal, தெரிஞ்சிருச்சு. There's no renal scarring, VUR கிடையாது. So there is absolutely no reason to put the child on uroprophylaxis. Not to be missed killers, there are many conditions where the child becomes very sick, where your immediate antibiotic factors that are more important in monitoring and intensive care. Acute encephalitis syndrome, toxic shock syndrome, dengue encephalopathy, all this, so many of these diseases are overlapping, and the season overlap ஆகும்போது many things tend to resemble the other. So antibiotic alone may not be the solution for many conditions. And of course surgical emergencies. Golden hour, குழந்தை கேஷுவாலிட்டிக்கு வந்த உடனே நம்ம ஓபில பார்த்திருப்போம், சைல்ட் சிக்கா இருப்பாங்க, நம்ம ஸ்டாஃப் கிட்ட சொல்லிட்டு இன்ஸ்ட்ரக்ஷன்ஸ் எல்லாமே எழுதிடுவோம். ஐவி லைன் போட்டுருங்கம்மா, இந்த இன்வெஸ்டிகேஷன்லாம் எடுத்துருங்க, ஆன்டிபயோட்டிக் எழுதியிருக்கேன் பார்த்து வாங்கி போட்டுருங்க, எல்லாமே நம்ம சொல்லிடுவோம். அந்த குழந்தை கேஷுவாலிட்டிக்கு போய் லைன் போடுறதுக்கு ஒரு 1/2 மணி நேரம். லைன் போட்டதுக்கு அப்புறமா அவங்களுக்கு அப்பாவை ரிசப்ஷனுக்கு அனுப்புவாங்க ரூம் போடுறதுக்கு. ஸோ ரூம் போடுறதுக்கு ஒரு 20 நிமிஷம். அந்த குழந்தை கல்ச்சர் இங்க இருந்து எடுத்து அனுப்பிடுவாங்க. பட் குழந்தை மேல ரூமுக்கு போய் அங்க சிஸ்டர் வந்து இன்டென்ட் போய் எழுதி அனுப்புவாங்க. இந்த பிரிஸ்கிரிப்ஷன்லாம் எழுதி கீழே ஃபார்மசில இருந்து போய் வாங்கிட்டு வாங்க. ஸோ கீழே அப்பா போய் வாங்கிட்டு வந்து ஆன்டிபயோட்டிக் இங்க ஆரம்பிக்கிறதுக்கு குழந்தை ஹாஸ்பிட்டலுக்குள்ள நுழைஞ்சு நம்ம பார்த்து கிட்டத்தட்ட ஒரு 1.5-2 மணி நேரம் கழிச்சுதான் a child with sepsis gets the first dose of antibiotic. This delay has to be averted. This may make a difference to 1 in 10 children. Remaining 9 will do invariably well, but that one child, it may be life saving. So always take a blood culture, adequate blood volume, blood culture before starting the first dose of antibiotic. Ensure that the first dose of antibiotic is given in the casualty itself, because ward-க்கு போனா it becomes very difficult. There is an inordinate delay. So as far as possible, at least in pediatrics, you can tell the casualty staff, give the first dose of antibiotic before shifting to ICU or to the room. These are all small things. If we implement, it will make a large difference in this, the way the system works. So if there is no response to antibiotic, so first day cefotaxime, second day ceftriaxone, third day betnazole. So if there is no response to antibiotic, what do? First, see, we all make mistakes, and the child may have one symptom resembling one disease on day 1, and the child may have another symptom resembling the actual disease only on day 3. So it is okay to revisit the diagnosis. It is okay to keep changing as long as we document everything in the case sheet. 4 வருஷம் கழிச்சு வேற ஒருத்தங்க கேஸ் ஷீட்டை பார்த்தாங்கன்னா இவர் எதுக்கு ஃபர்ஸ்ட் டே இதை போட்டு ஃபோர்த் டே அதை போட்டிருக்காருன்னு அவங்களுக்கு புரியணும். So as long as you note your observation and you justify what you're doing, it is okay to revisit the diagnosis at any point of time during the course of treatment. as long as it benefits the child. Revisit culture reports. The child is not improving, go back and see if the culture has been taken. Follow up what is a culture report. Recalculate the drug dose. So if many a time அதாவது நம்ம மெடிசன் எழுதுறோம், மெடிசன் ஸ்டாஃப் கொடுக்குறாங்க, பட் நம்ம எழுதுறது தான் குழந்தைக்கு போகுதான் நிறைய தடவை நம்ம பெட் சைடு நின்று பாக்குறதே கிடையாது இல்லையா? It's a way we have been trained. So it's their duty, the staff nurse duty to load the medicine and to give the infusion. But many often we don't verify to see if that is what is going. So everybody, and especially in COVID times, lot of people have been out of jobs. Hospitals are also under a lot of stress. So they are trying to achieve a lot of good work with a less number of support staff. So the staff are also very stressed. There is a high chance of mistakes happening in this period of time, more than at any other period of time. So it's not about fault finding, it is about filling the gaps in the system. So whenever possible, not all of us are, we're all not very, very busy. Thanks to COVID, எல்லாருமே practice கொஞ்சம் படுத்துருச்சு. So we can actually take some time to see what drug is by the bedside. Make sure நம்ம எழுதினது தான் அங்க இருக்குதாங்கிறத ஒரு வாட்டி செக் பண்ணிருங்க. So think about the choice of drug. நம்ம ஃபர்ஸ்ட் டே எழுதினோமே, இது இந்த குழந்தைக்கு எனக்கு ஆக்சுவலா தேவையா, இதுவே ஓகேவா? Check the bedside, then justify the need to change the antibiotic. If you are changing, please document. The role of documenting has not been stressed enough. Avoid polypharmacy. So 2-3 drugs எல்லாத்துக்குமே கேட்கற மாதிரி நம்ம ஒரு சில prescriptions வரும். So avoid polypharmacy. Targeted treatment at the appropriate dose is always welcome. As far as possible, if you're suspecting bacteremia, no role of steroid. There are a few children with acute lymphoreticular malignancies who present to us with fever and with increased inflammatory markers. That child, if a peripheral smear has been done on day 1 of admission, a good lab is going to pick out the blast. But if somebody outside has given steroids to the child, tappana fever korayano, give steroids, the blasts are going to disappear from the smear. Your diagnosis is going to be delayed. You're going to give antibiotics for 5 days. You're going to wait for culture. The child is going to worsen, platelets are going to drop. Then you're going to get somebody's opinion, or then you're going to do a bone marrow. Everything is delayed because one of us chose to give steroids. So as far as possible, please remember the role of steroids in our practice is very, very limited. It must be very, very choosy. So amma coming, I'm sick, the kids are all sick, I can't sleep, there's so much coughing, I can't cope. Surely an antibiotic will help. So we are all under a lot of pressure to satisfy our clients. நம்ம வைத்தியம் பண்றது பாதினா அவங்களுக்கு கன்சோல் பண்ணி குழந்தை பத்தி பயப்பட வேண்டாம்னு வார்னிங் சிம்டம்ஸ் சொல்லி அவங்களை ரீஅஷ்யூர் பண்றது தான் இன்னும் பாதி வைத்தியம். So but at the same time, our patients, I have learned this from Dr. SBS, my teacher, they are all used to him. They are all used to his way of practice. His patients will not come and nag him for antibiotics even after 4-5 days of fever. They all know. So it's actually நம்ம அந்த மாதிரி நம்ம இந்த மாதிரி தான். This is the way we practice, and they will understand. When we start succumbing to the pressure, we lose track in the way, and it's very difficult to get on track and practice medicine ethically. So thank you all for your patient listening. I've stuck to time. Thank you so much for the opportunity, Ismail sir.
Thank you, Dr. Sudarsana. It was a really wonderful talk. நான் எப்படி இந்த பிரசிடென்ஷியல் ஆக்ஷன் பிளான்ல திங்க் பண்ணணும், ஒரு பெரிஃபரல் பிராக்டிஷனருக்கு எப்படி இந்த இது கொடுக்கணுங்கிறது, ஐ திங்க் ஒரு கிடிப்புள்ளைக்கு பாடம் எடுத்த மாதிரி, பீங் அன் என்விரான்மெண்டலிஸ்டா என்னன்னு தெரியல, நீங்க அவ்வளவு அழகா ஒவ்வொரு பிராக்டிஷனருக்கும் சொல்லி கொடுத்தது உண்மை. எஸ்பெஷலி கொலோக்கியலா தமிழ்ல அழகா பேசுனது மனசை தொட்டது. நாட் ஓன்லி தட், ஐ திங்க் இட் இஸ் மேட்டர்ஸ். You can lecture so much, but only thing is it has to reach the people's head. Of course, the way you had brought out in such a way, in a very simple language, I think people will really understood the different spectrum of diseases and the way what antibiotic should be chosen, how long should be given, and what are all the precautions you should take, and what is mean by the golden hour, not to miss in the bedside manners, how to see a patient, everything you dealt in such a good way. I think the practitioner would be really benefited for that. So thanks for your wonderful lecture.
Thank you very much, sir.
I don't see any questions in the screen. I would request Dr. Raghavan to say a few words. A comment from Raghavan, Trichy branch president.
Good evening, everyone. Thanks, Sudarsana, for that was a beautiful lecture.
Thank you, sir.
And you spoke very well, covered all the points. And like sir said, you covered about the golden hour starting immediately the antibiotic, which we don't do generally. You stressed upon that. And I would like to really congratulate Dr. Ismail for the persistent perseverance with which he is going through this pulse, insisting that all the subspecialties do, all of our branches do it, and we repeat it till it goes into our head. Congratulations to you, sir.
Thank you, Raghavan. I think having taken up, I think we need to be persistent and consistent also.
It's a very nice quality which you have, sir.
Thank you,
Dr.
thank you. I do see the presence of Aram Sendil, past president, my good friend. I think Sendil.
Yes, Ismail. Yeah, I'm here.
Yeah,
it was a wonderful presentation by Dr. Skanda.
Thank you, sir.
She is always wonderful, and I know her. And only one thing, one query, a practical point, before giving an antibiotic, every time, what is your practice and what is the advice usually? Every time you give a test dose, or how do you go about it practically?
சார் நான் ஒர்க் பண்ற நர்சிங் ஹோம்ல வந்து இட் இஸ் பிராக்டிஸ் அடல்ட் ஹாஸ்பிட்டல் அது. அவங்க அதே தான் பீடியாட்ரிக்ஸ்க்கும் ஃபாலோ பண்றாங்க. ஸோ அதனால எல்லாருக்கும் அவங்க டெஸ்ட் டோஸ் கொடுத்துட்டு தான் ஆன்டிபயோட்டிக் கொடுக்குறாங்க சார். தட் இஸ் வாட் ஐ ஹவ் சீன். நான் சொன்னதே இல்லை, பட் அவங்க அதான் பண்றாங்க. ஓகே,
இல்ல அது will it go for a delay? நீங்க சொன்னீங்க இல்லையா, அந்த இமிடியேட்டா அந்த கேஷுவாலிட்டிலே ஃபர்ஸ்ட் டோஸ் கொடுத்துருங்க அப்படின்னு சொன்னீங்க. சோ அதுக்கு வந்து ஒரு டிலே வந்துருது அப்படிங்கிறது தான் என்னுடைய கன்சர்ன்.
நம்ம ஒரு செப்டிக் ஷாக்ல ஒரு சைல்டு பார்க்கும்போது நம்ம ஐ திங்க் we can it is all an individualized thing sir. Documentation is important. I think you just bypass the test dose and you can give off the first dose of antibiotic for a child in septic shock in the casualty.
Okay, thank you.
Yes sir, thank you sir.
Thank you, Sindel. I think Shiva is there.
Yes, sir.
Dr. Lakshminarayan, sir. Dr. Lakshminarayan, sir, please unmute. Unmute, sir. Jailan, sir, unmute.
Test dose.
Yes, sir. Yes, sir.
Is only a legal escape. It doesn't help anybody.
Sir,
legal escape. For any drug, for that matter. And test dose கொடுத்துட்டு தான் சார் போட்டேன். அதனால இப்போ I'm escape from the punishment. அதுக்காக போடுது. Test dose doesn't give any benefit at all. Even those days of penicillin, test dose போட்டுட்டு கொடுப்போம், அப்பவும் ஷாக் வரத்தான் செய்யும்.
I think I do agree, sir, but actually after the Consumer Protection Council kulla நம்ம வந்ததுல இருந்து a lot of practicing methods have changed.
That's why I call it a legal escape.
Yes, sir. Yes, sir. I do agree with that. Thank you, sir. Thanks for your comment. Shiva?
Sir, good evening, sir.
Practicing right.
Sir, illa sir. Good evening, brother. வீட்டுக்கு போயிட்டு இருக்கேன் sir.
Okay.
Sudarsana is a very good presentation. So I had one doubt. So even though I am in WHO, so WHO and IMNC guideline says for the treatment of dysentery, first line ciprofloxacin, with the pediatrician we are using only the cefixime. Since nowadays fluoroquinolones usage is little bit reduced, not little bit, almost totally reduced, since being a second line drugs for TB. And if refractory to cefixime, we can go for azithromycin as mentioned Palliraman sir in one meeting. So what's your experience, whether you are using cipro or ofloxacin or only cefixime?
My teachers have not used cipro, so naan cut copy paste of my teachers. I have never used cipro, so my choice has always been cefixime.
Okay, good. The presentation was very nice as your own style.
Shiva. Thanks, Shiva.
Thank you.
Yeah, thank you all of you. I think there are no more questions. I think, is there anything? I have to check it up in the chat box. No, it's only compliments for Dr. Sudarsana. Thank you, Dr. Sudarsana. Thank you, the Trichy people and all the delegates who have attended this meeting. Thank you so much.
Thank you so much, sir. Thank you very much.
Thank you.
Thank you, sir.
Thank you, Shiva.
Thank you, sir.